Okay, good afternoon. Welcome to everybody. This is quite a venue, huh? Some of you were with us last year. We went to City Harvest all the way in Sunset Park, and that was a great space. But I think my staff really liked the Gilded Age, so we ended up here this year. It's really cool. I've only been here once before. It's very like a touch of old world New York. So I'm David Sandman. I'm president and CEO of the New York Health Foundation. Thanks to all of you for being here today. Can't hear? I've seen a lot of old friends, familiar faces. I met some new people as well. Hello, my new friends from Binghamton. Where are you? There you are. All right, well, welcome to all of you. For those of you who may not be too familiar with the New York Health Foundation, we're a private, independent, and statewide foundation with a mission to improve the health of all New Yorkers. We focus on a number of key priorities, starting with the reason that we're all here today. We work on connecting New Yorkers with the food that they need to thrive through our Healthy Food, Healthy Lives program. We also work on strengthening primary care, and we work to improve the health of veterans, 25% of whom experience food insecurity. We also have a pool of flexible funding through our Special Projects Fund, and we use that to address emerging health needs. So if you want to learn more about us, I encourage you to visit our website, definitely sign up for the mailing list, tell us what you're interested in, and if you really want to keep up with us on the regular, then follow us on LinkedIn and X, and you will know there's always something going on at the foundation. So it has been a pretty wild year for health and food policy, to say the least. We did this conference a year ago, as I said, and it was just shortly after the election. We didn't know much then. We knew for certain that Trump had been elected, and we knew that Republicans controlled both houses of Congress. We had some amazing speakers. We all did our very best to read the tea leaves, try to figure out what was coming, but we could not have imagined the magnitude of the policy changes and the funding cuts that we are facing today. It has definitely exceeded expectations, and I do not mean that as a compliment. Just at the top of the list, New York's going to lose something like $1.4 billion in SNAP funding. 3 million New Yorkers rely on SNAP to lessen hunger and food insecurity. And, the truth is plain and simple. The choices that were made in Washington are going to leave New Yorkers poorer, sicker, and hungrier. We are playing defense, and today we are focused on actions to safeguard food access for all New Yorkers. This is the food crowd. You know that food's essential to our health and well-being. At its very core, of course, food is nutrition, but it's so much more than that. Food is part of our culture. It's part of our traditions. Food brings us together. Food can be how we express love. I had a sick friend over the weekend, and the first thing I did was show up with food for them. And food can be medicine, but many New Yorkers don't have the food that they need. An analysis that we did at the foundation earlier this year found that hunger rates in New York now exceed as high as they had risen during the earliest days of the pandemic. 1 in 10 New Yorkers, that's 1 in 10. Think about that when you go home tonight. Look around you on the subway. More than 2 million people report not having had enough food to eat last week. 1 in 10, think about that. Those rates are even higher for Black and Hispanic New Yorkers. And a report that we published just last week focused on older adults, and we found that more than half of older adults in New York have difficulty accessing affordable, quality food. When people don't know where their next meal is coming from, they can't be healthy. So think about those numbers and look in people's faces when you go home tonight and think about which family is going to be hungry. But not everything is doom and gloom. We did not bring you here just to depress you. In times like this, it's particularly important to celebrate the wins when they do come. We really are celebrating an enormous win, and that is New York's enactment earlier this year of universal school meals for every child in this state. Go ahead, you should. The new school year got underway just last month, and for the first time ever, every child in every grade, in every school across New York has access to free school meals without stigma, without shame, and without financial barriers. It's a proven way to improve children's health, improve educational outcomes, and bring more equity into our system. There's a lot of people who contributed to that win. A lot of you are here. I'm going to definitely leave some people out. I saw our friends from Ag and Markets who were here. I saw friends from the Health Department who were here. I'd really be remiss if I didn't give extra special congratulations to both Hunger Solutions and community food advocates. Yes. They were just unwavering, undeterred in that effort. It took almost 10 years or so of that campaign to get over the full finish line. But great things take hard work and patience. And I know that together, everybody who's here in this room, we can and we will accomplish so much more than that. So we've got a great day lined up for you. I was supposed to tell you what's on the menu, pun intended. I don't know. This is what we're going to do today. If you're cool and modern, you can scan the QR code that's in your materials. If you're like me and you like a hard copy, we have some of those on hand as well with the agendas. We're going to begin with a keynote address, followed by our first panel discussion. We'll take a break for networking. That's part of why you're here too, to see your friends and colleagues, meet new people. We'll follow that with a quick take talk and then a final panel to wrap up the day. Closing remarks, and don't leave because we've got a wonderful reception for you all, food and drinks and all of that, so stay and hang out like you did last year too. Of course, my deepest thanks go to the Foundation's staff for their exceptional work putting all of this together. Again, I can't name everybody, but I have to particularly thank Julia McCarthy, Andrew Barrett, Avital Havusha, Liz Ward, and Erica Van Boxtel. You all did the heavy lifting, and you somehow made it look easy. All I did was show up today, so thank you. And now, it is my honor to introduce our keynote speaker, Corby Kummer. Corby has lots and lots of titles and roles. He is the executive director of the Food and Society program at the Aspen Institute. He's a senior lecturer at the Tufts Friedman School of Nutrition Science. He's a longtime senior editor at The Atlantic. He's a featured commentator on food and food policy every single week on Boston Public Radio. And he has received 6 James Beard Journalism Awards. So many titles, and if you want more Corby, there's more Corby to be had. Be sure to follow him as well. So we're most eager to hear from him. Please join me. Let's give a very, very warm and hearty welcome to Corby Kummer.
Good afternoon, everybody. I am really excited to be here, and I have to thank Liz Ward, Julia, and Erica Von Boxtel, my former colleague at the Aspen Institute, for getting me here. It's both an honor and a little intimidating to talk in front of people who do the groundwork every day and are essentially my betters. So correct me when I spout misinformation about New York statistics that I pulled off the internet, and you are all right here on the front lines, and you are the people my program, Food and Society at the Aspen Institute, works to spotlight and help forward your work every day. So it's exciting and inspiring to be here and to see so many of you here. The Health Foundation, of course, has long acted as a kind of civic conscience, publishing hunger metrics, which you're hearing about from David Sandman, commissioning stories, pressuring public systems to respond. It's you who make it harder for elected leaders to pretend that hunger is someone else's problem. And I hope there are elected leaders here or people who represent elected leaders. So important to address and be part of the solution. So let's begin with some numbers you're familiar with and you're probably about to correct. In New York State, latest data that I found showed a 10.4% rate of food insufficiency. In New York City, the numbers are higher. 14.6% of households, or over 1.2 million people, living with food insecurity. Some neighborhoods in the Bronx, parts of Brooklyn, local survey data suggest rates nearing 30%. And how does that compare nationally? What's the national framework? In 2023, the U.S. household food insecurity rate was about 13.5%. So statewide, New York is slightly better than average. I saw my friend Natasha Pernica, who's going to leap up and correct me because she's so in touch with New York State data. But the city is distinctly worse, especially in high poverty zip codes. And that very food insecurity household survey rate just announced cancellation by the feds, so we wonder where we're going to get our data to be able to talk about in future years. I'm an optimist. I keep hoping it's actually going to continue and some private foundation is going to take it over as different private philanthropies are taking over some of the global health surveys that have been abandoned by USAID. So there's a goal for all of us to try to find funding to continue the food insecurity survey. As you all know, food insecurity increases the rates for hypertension, complicates diabetes control, drives pediatric developmental delays, weakens immune system response, and exacerbates mental health burdens. A connection that is only recently being given the attention that it really needs. Mental health is something I hope Food and Society at the Aspen Institute gets into in a big way in future years. So you know that we need to treat food as a vital social determinant to close health gaps. And that's where Food is Medicine comes in. And because Food and Society has spent, 6 or 7 years very actively doing Food as Medicine work, I'm going to concentrate on it today. But I didn't begin as a health policy wonk. I began wanting to eat well and to write about the stories behind the people who help everyone do that. Pastry chefs, my motto is I break for bakeries. Salt makers, fishers, farmers. I wrote one book on coffee and another, the first in English, on the slow food movement. Slow food explicitly said, I hope a lot of you have heard of slow food. I hope it's active enough in New York that you actually encounter programs they sponsor. It explicitly, it really was the first to say they wanted to promote foods that hewed closest to history and tradition, as I did, but they went farther. They drew links from that kind of food to agriculture, environment, and interconnected rural economies with a sophistication of critical thought I hadn't encountered. And so I decided I'm going to write a book about it. I started proposing articles and concentrating my own writing on people trying to make food healthier on a large scale as well as a local scale, particularly in the food industry, which in the early days of the Obama administration and Michelle Obama's Let's Move campaign were working to reformulate industrial food. Reformulation is a crucial effort. It's invisible to many consumers by design. Healthier food is seldom a winning business proposition unless you're in the high-priced province of Whole Foods. I learned that policy, regulation, and federal spending were the best ways to make food healthier. For example, the recent attention on food colorings and food additives, which so far is largely voluntary compliance, except for 2 FDA regulations that were put in place by the Biden administration but are continuing. That used to fall under the category of stealth health. Companies would do it, but they wouldn't talk about it. It was not considered anything that would ever win more customers. Now it's something that can kind of come out in the open and talk about. So this realization about the different levers of change led me to start Food and Society at Aspen. And our aim was not to romanticize food, but to build a rigorous, equitable, policy-aware movement, which you're all doing every day. We ask, how can public health systems and food systems help make the healthiest food the easiest food? How can clinicians prescribe produce or home meals? What would it take to make those prescriptions reimbursable? And how do we do this all while centering equity? So a lot of people who've heard of food as medicine don't know its roots in the HIV movement. So I always find it useful, and it's my own roots in getting involved, to go through it. In the late 80s and 90s, community organizations responded to the HIV/AIDS crisis, as well as chronic illnesses and homebound seniors, by making meals for people too sick to shop or cook. In New York, God's Love We Deliver, which began in 1985, and I hope we have God's Love people. We do, we have hands up, was among the first to deliver what we now call medically tailored meals. Community servings in Boston began in Boston 5 years later. I was a founding board member. I'm still board emeritus, and I show up at meetings and torment people. Those meals were not billed to insurance. It was private philanthropy and donations. But the outcomes caught researchers' attention, and it's the beginning of the food as medicine and medically tailored meals movement. In 2015, a researcher named Seth Berkowitz, a personal hero of mine, and colleagues published an influential analysis showing that in a cohort receiving medically tailored meal interventions, hospitalizations dropped by 50%, healthcare cost savings reached 16%. In 2018, a health affairs follow-up confirmed those results over an extended period. In subsequent years, Hilary Seligman, I hope you all look up Hilary's work. She's a great personal hero of mine at UCSF. Extended that work. In certain populations with diabetes or congestive heart failure, adherence to tailored meals was associated with fewer emergency visits, improved biomarkers, and reduced healthcare system utilization. A 2023 post-pandemic meta-analysis of 14 randomized controlled trials found that while effect sizes varied, many interventions showed statistically significant improvements in food security, HbA1c levels, blood pressure, diet quality, with cautions that are important to note about sample sizes and short follow-up. We have to add, many of these programs are short-term, 3 to 6 months. Small in scale, hundreds to thousands maybe, of participants, and conducted in settings already likely to show positive results. The reason we have to be very open about these shortcomings is that they haven't yet been the multi-year state-level randomized expansions with full actuarial validation that would convince actual actuaries and healthcare payers, both private and public, that food as medicine would become the covered benefit we want it to turn into, rather than being the province of pilots and 1115 waivers, which I'll get into. So that's why Food and Society built our Food as Medicine Research Action Plan. It was initially a 3-year research and writing effort with, as a primary author, Emma Clippinger, who I think works with the Health Foundation. I was dreaming was going to be here today, one of our 3 primary authors in 2022. Then last year, we published an updated Food as Medicine Research Action Plan, easily available online. I invite you all to look at it. We tried to make it incredibly enticing, really well designed, and really concise. And we tried to go beyond hope and ambition to articulate a blueprint for the next decade of research. And I think I've left out the bragging points that HHS and the NIH and Rockefeller Foundation and American Heart are all kind, big promoters of our research action plan, because we were the only kind of one-stop source for all of the peer-reviewed data into medically tailored meals, medically tailored groceries, and produce prescriptions. So here are some of our core findings from the revision we published last year. Lack of standard metrics across states. So some programs measure hospital readmissions, others measure diet change. Participant satisfaction is huge and crucial. But if you can't compare those metrics state to state or intervention to intervention, cross-site comparison is nearly impossible. Again, you're not building the national database you want payers to recognize. Short duration, limited scale, which I already talked about. Equity blind spots, something we were very conscious of from the very beginning of our work, and I'm sure drive your work every day. So immigrant populations, non-English speakers, people in transportation scarce zones, people with limited digital access, people with disabilities, many get left behind. So programs designed without a kind of co-design to find them often fail in these communities. And I know everybody here is very aware of that and designs around that, but not all of your peers do in every state. Then fragmented integration. Food as medicine programs too often stand outside healthcare systems. We define, and many define, referrals to a healthcare system and a nexus to the healthcare system as what we call food as medicine. But referrals often rely on manual processes, not electronic health record triggers. Payment and reporting infrastructure is disjointed. Feedback loops are weak. There isn't a common software platform. Many states work on that. Are any of you familiar with Coding for Food? Terrific effort out of California. They're trying really hard for data integration. Our friends in Canada are trying to just start food as medicine, and they have this huge built-in advantage of mostly countrywide data interoperability. That just seldom exists in the U.S., but it's a dream. CBO capacity constraints. You're all familiar with community-based organizations. You're all frontline deliverers of meals or groceries, but they often lack billing infrastructure, compliance expertise, IT systems, staffing with credentialed dietitians, not because they don't want it, it's because they can't afford it, or experience in Medicaid reimbursement. And I know that New York City and state with the 1115 waivers are working hard to overcome exactly those barriers. Reimbursement uncertainty, design fragility, federal and state rules around match rates, Medicaid room and board barrier, varying eligibility rules, and state-level cost share burdens introduce fragility into program models. So many services remain grant-funded rather than institutionalized or the kind of hefty federal reimbursement we want. So some of our key recommendations, which all these point to, is define a common outcome set. So we suggested a minimal core set of measures: food security change, hospital utilization, clinical biometrics, program costs, equity stratifiers, and participant-reported outcomes. I should add that Hillary Seligman, Seth Berkowitz, and a guy named John Lumpkin in North Carolina were working with HHS to exactly define these research metrics, very much like what we were saying, but in an official way for all of the ongoing new American Heart Association and research that's underway right now. Fund CBO capacity building, grants or technical assistance to help CBOs become ready for waivers, implementing billing systems, compliance operations, data reporting, legal support, training in HIPAA, and health data exchange. So many payers, if you'll get them on a private Zoom call, will say, I believe in CBOs with all my heart, but I can't get into HIPAA problems. And they just can't guarantee me HIPAA compliance. So finding ways around that, a huge problem that I think the social care networks I'll be talking about, and you're very familiar with, are working to solve. Embed screening and referral workflows into clinical systems, something Food and Society is working on with various large hospital systems, but use EHR triggers, care managers, warm handoffs, closed-loop referrals so that food needs get folded into medical plans, not tacked on at the end. Design programs with community voice. From the beginning, when we started this work in 2018 and 2019, a flaw was that so often came up as something none of you would ever be accused of, which is go into the community and ask what they need first. Don't tell them what they need. Don't come in with a whole program designed, a whole diet, a whole intervention you manage to get funding that you think they're going to love. Go in first. And a reason I mention how often and how long that came up is because it still comes up. So many people still say that's not, it's honored in the breach. And very often research funders would say, we believe in it, but we don't have time. We can't fund those kind of community meetings. So that's just been a problem from the time we began. Time to get the community voice before designing interventions. Pushing for regulatory clarity and flexibility. Now, we did write these before January 20th, but advocate with CMS to clarify match rules, allow partial lifting of the room and board restrictions in certain settings, expand waiver flexibility, or create new pathways for nutrition benefits. And then sustainability for day one. Require that pilot proposals include a transition plan. I know God's Love cares about this. Community Servings has been caring about the stepping down problem. After you come in with an intervention that you've worked so hard to get funded, what happens afterward? What's the access to food after you work so hard to get new populations access to culturally appropriate food they'll actually use, they'll actually eat, that can show actual health improvements? What do you do when the funding ends? And how do you do step-down programs? Still a big, big question. So if states, funders, and federal agencies treat these as just aspirational, it'll still remain a niche movement. But if we act on them, we can push food as medicine into infrastructure, which is what we really want to see. So what's happening today? No Food as Medicine initiative can succeed if the safety net is eroding. So under Trump 1, benefit adequacy was weak, eligibility was tight, administrative funding was stressed. During COVID, which now seems a kind of golden age, emergency allotments and flexibility waivers significantly expanded reach and benefit levels. But when emergency allotments ended in late 2022 to 23, those are mostly national. I don't know what the New York City tapering off dates were. Average benefit reductions of about $95 a month per person occurred. It was the steepest contraction in SNAP since post-Great Depression reset. And since last January, this Trump 2 has floated proposals reducing administrative funding, tightening eligibility reviews, limiting categorical eligibility, reinstating stricter work requirements for able-bodied adults without dependents. And you're very familiar with the draft budget language suggesting cuts to SNAP operations hovering in the low billions. What does that mean for New York? If federal cuts reduce benefit levels or eligibility thresholds by even 5%, that could erode hundreds of millions in food purchasing power statewide. And for New York City, hundreds of thousands of households will face greater strain. The ripple effect touches grocery retailers, local economies, and food program demand. WIC. I know we have WIC specialists here because I talked to one right before this talk. It's historically more stable. We call it the first National Food as Medicine program. As you all know, it's a result of the first White House Conference on Hunger, Health, and Nutrition in 1969, and it was enacted by, surprisingly, the Nixon administration. It's enjoyed bipartisan support as a preventive maternal health program. But 2025's budget process includes cuts to discretionary appropriations. Congress had to authorize emergency funds to prevent waiting lists in many states. In New York, only about 50% of eligible women and children participate, often due to paperwork barriers, clinical hours, language or perceived stigma. I'm smiling because I wrote this before I met a woman that Julia introduced me to who's working exactly to increase enrollment and reduce those barriers. And I'm sure that so many of you are doing exactly this kind of work. So, first prescription for health is still a functioning federal nutrition program, and whatever happens to the 1115 waivers I'm about to talk about, we still have to concentrate on SNAP and WIC as our frontline nutritional benefits. And we have to think of food as medicine as not only being what 1115s pay for, but making the best possible use of SNAP and WIC, because it might be what we're left with. I say that privately, and here I am saying it in front of a lot of people. So 1115 waivers is where the disruption happens or fails. As of now, 16 states have approved or are pending 1115 waivers or demonstration plans with explicit nutrition or food support components. Among these, 8 states have nutrition-inclusive demonstrations already operating. These waivers typically include medically tailored meals, medically tailored groceries, which is what we found in our research action plan had kind of the best bang for the buck. Nutrition education, a lot of which just disappeared with SNAP Ed. produce prescriptions with debit cards or vouchers, and food-related care coordination. Only one state, North Carolina, has publicly signaled rollback in its food benefit pilot. It cited the cost of required state match and escalating expectations. It's a particularly alarming sign because North Carolina had perhaps the best integrated statewide food as medicine delivery and integration model, and was a model for every other state with or seeking a waiver. Have any of you worked inside of North Carolina or studied what it did? So incredibly admirable, and it was all 100 counties, an easy figure to remember, constant visits to all 100 counties, and integration among the Blue Cross Blue Shield programs there that was really the envy of any other state looking to get wide buy-in for food as medicine. But it wasn't the feds, it was the state itself who in April said, we're worried about continuing with our match and that the match is going to increase. They had until September 30th to reverse it, and they haven't yet. So there's still some sort of hopes. But North Carolina, it's an alarming example. So New York's health equity reform waiver, and here I get into stuff I pulled from the internet, and you do every day, so you can all just say, no, if I'm saying wrong things. Pledged over $6 billion in combined federal state funding to integrate health-related social needs, including food security across Medicaid. And do you say NY-HER? How do you pronounce the acronym? Somebody yell it out. NYHE. NY-HER. Okay, like NYCHA. Okay, so great. Okay, NY-HER. Medicaid members can receive medically tailored meals or groceries, often up to 6 months. Nutrition education, which has disappeared elsewhere. Pantry top-ups, cooking classes, kitchen supplies, reassessments are reimbursable. And when that's perhaps the single best way to ensure long-term behavior change. I believe a lot in SNAP-Ed. I believe a lot in education and demonstration kitchens, and bringing about long-term behavior change through education and making people feel they know how to use produce that they get with produce descriptions and want to keep finding it if there's funds and even if they have to stretch dollars. I'm sure we have H&H people, New York City Health and Hospitals representatives here. Certain community clinics are aligning their produce prescription pilots and meal voucher programs with NY-HER rules so that referrals from city hospitals become eligible, a huge, important population under the state waiver. And in effect, New York City's safety net system has been retrofitting itself into the waiver architecture that was going in New York State for a while, and it's only recently begun in New York City. But there's a 2027 expiration looming, and if New York doesn't embed these nutrition supports into standard Medicaid managed care contracts or carve them into value-based payment models, infrastructure could collapse. So you will have to worry about state matching burden and advocating for state matching, this room and board prohibition in Medicaid. So New York's waivers, like every 1115 waiver, should be thought of as not an end, but a launch pad. So a couple of people, and I'll just mention a few examples that will make your teeth gnash, because it happens that Food and Society at Aspen runs something called the Food Leaders Fellowship, and we have a number of Food as Medicine fellows. The woman I met who's helping increase enrollment in WIC does just this kind of work. So I'll start with some of the differences that people can make within their organizations and themselves. So Richard Kummer of Hunger Free Oklahoma, he leads their Double Up Oklahoma program, Double Up Bucks, Wholesome Wave. All of you are very aware of this. And it works a lot in tribal nations, a hugely important population in Oklahoma and surrounding states. And they've embedded food insecurity screening into Medicaid systems and built a robust redemption tracking logistics backbone. You probably know Oklahoma was the first state this year to pass a food as medicine bill and legislation. No funding yet. So there's a small catch. It hasn't been funded yet, but at least the state passed it. So Oklahoma, Texas's ban on closing the grass loophole. There's lots of interesting state work in legislation that's happening, but it hasn't been funded yet and it hasn't gone into effect yet. So these are some of the programs we're all watching. Wholesome Wave, Brent Ling, who leads all of their government relations work and lobbying, is one of our new crop of Food Leaders Fellows, so that patients seeing a clinician in a safety net clinic could get a voucher or card that works in nearby markets. Josh Troutwine, I hope a number of you have met him at About Fresh, which is a food, health, fintech, and social enterprise. He, I imagine, works with a lot of your organizations. It's a digital benefit platform enabling health payers, providers, and community organizations to fund healthy food purchases at retail grocery outlets and markets. It's 12,000 stores nationally and very active in New York City and Boston. They have a lot of interesting data they're able to collect, and collecting data based on utilization is something that it's becoming much harder to get SNAP use among retailers because of the Supreme Court siding with retailers and keeping that data opaque. But when people like Josh and the woman I met right before this start being able to use what federal dollars there are to help clients access nutrition, they have a rich resource of data that they build and can analyze, and I hope we'll share with others, because sharing it is really what everybody should be doing. So what we should build next, I'm no one to tell you because all of you do the work all the time. You're the experts, but here's a few possibilities given food as medicine's history and the current moment. What everyone wants to do is embed food supports into Medicaid contracts. A way to get there is to use our research action plan, core metrics, food security scores, utilization, biometrics, cost, equity stratifiers to build a statewide data portal for waiver-eligible food interventions. Every state, like Natasha and so many state people I haven't met yet, in New York want to ensure that rural counties, upstate areas, tribal territories, outer boroughs get proportional access to interventions. National goals that state by state are being piloted using private philanthropy, I wish it were public, subsidized dietitian positions in CBOs, cross-train community health workers in nutrition and delivery logistics, and creating a credential track for food care navigators in healthcare systems, what social care networks are doing now. Right now, these are firmly in the dream category for national implementation, but we are now doing, we at Food and Society, a community action plan to help CBOs understand what food as medicine means, how they can get it reimbursed, and how getting into it and getting their feet wet can help. And I invite all of you to go onto the LinkedIn site and say, I've got a great example, you should be spotlighting me, because we're going to start in the end of November. We've been spending a year gathering inspiring case studies. So as Congress debates the next farm bill, states weigh budgets, we should all remember that food as medicine works. It reduces hospitalizations, cuts costs, and restores dignity, and builds the evidence base that will convince future payers that that prevention of future illness and loss of dignity and a full place at the table are worth paying for. So New York Health Foundation is the conscience of that work. It's a recipe worth perfecting with many dedicated cooks at the stove like all of you. Thank you for inviting me today.
Please welcome to the stage healthcare reporter for Crain's New York Business, Amanda D'Ambrosio.